Hello, I'm Mandana Khalili, Professor of Medicine and the Director of the UCSF Research Coordinating Center's Investigator Development Unit. This is of the NIMHD Multiple Chronic Diseases Consortium. I'd like to welcome you to our monthly training webinar. Before we start, we would like to acknowledge the Ramaytush Ohlone people, who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon, their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Well, today we're honored to have Dr. Diana Redwood speak to us about addressing health disparities in rural and remote areas, improving colorectal cancer screening among Alaska Native people. Dr. Diana Redwood is a senior epidemiologist at the Alaska Native Tribal Health Consortium. She's worked in the Alaska Tribal Health System since 2004. Her expertise are in public health and epidemiology with a focus on cancer screening and prevention. She conducts research into novel methods of colorectal cancer screening outreach and new screening methods for the Alaska Native population. Dr. Redwood is also an Alaska representative to the National Colorectal Cancer Roundtable and is a passionate advocate for improving the health of Alaska Native people through decreasing the burden of colorectal cancer. Dr. Redwood, we're very happy to have you and excited to hear your talk today. Thank you.
Wonderful. Well, thank you very much. I'm honored to be invited to present today and to talk to you a little bit about some of the work that we have done in Alaska to improve colorectal cancer screening and research among the Alaska Native population. I will say that I can't always see chat when I am presenting, so I very much encourage people to put questions in the chat, to ask questions. It's always enjoyable for me to hear the things that other people are doing and to share knowledge. The more I give talks, the more I learn from other people. So let's get started. I'm going to share my screen. So just to confirm, you can see slides?
Yes.
Lovely, thank you. So I will actually start out by adding my land acknowledgement as well, thanking the Dena'ina people on whose traditional lands I live, and thank them for their past and present stewardship of the waters, plants, animals, and spiritual practices of this place. This beautiful land that I live in. I took this picture, so I encourage all of you to come to Alaska and visit. It's very beautiful here. So Alaska Native people are very proud of their history and their heritage and of how that has continued on into current traditions and life in Alaska today. But Alaska Native people do face a challenge and a burden, one of the world's highest rates of colorectal cancer. Alaska Native people not only have twice the incidence, new cases of cancer, but also twice of the deaths due to colorectal cancer as US whites. It's the second leading cause of new cases of cancer among the Alaska Native population. So it's something that there's this sizable health disparity that we are not always sure exactly why it is happening. And so that's what has really led our tribal health leadership to want us to work on this. And it's a disparity that has really persisted for over 40 years, as nationally there's been a big decline in colorectal cancer due to increased use of screening. But among the Alaska Native population, this high incidence really has persisted and has continued even as it has declined nationally. And the same for mortality. You see these declines nationally, but really we've been persisting, just sort of not going down. And it's something that, again, is very challenging. And every time we have a 5-year new cancer report out, I'm like, okay, this is going to be the year that it finally goes down, and it still hasn't. So that's what I'm waiting to see. It's also the incidence is higher among Alaska Native people at every age group. So, even at the earlier age groups, it's as high among 40 to 49-year-old Alaska Native people as among 50-year-olds US whites. So this is one of the reasons that we actually have engaged in slightly different screening guidelines at the Alaska Native Medical Center and for the Alaska Native population to begin screening earlier, partly because of this just higher rates and the earlier ages. And this high mortality rate was really shown. This was a study done a couple of years ago now that looked at mortality rates among US counties. And really, you sort of see Alaska, although, as you know, we don't float below the bottom of California. We are farther up north, but we have this really high rate in the northern and western portions of the state. And that's really a reflection of that's where the Alaska Native population primarily lives. And Alaska, we often think about what places are considered frontier and remote zip codes. Basically, everywhere in Alaska, except maybe the little tiny pockets, are considered this frontier and remote. Without roads, it's very challenging to get around. It's very challenging to deliver healthcare. So that really influences how we have to carry out the work that we do, how we address cancer disparities, how we address healthcare delivery. And the Alaska Native healthcare system, I don't know how everyone, how familiar you might be with it, so I want to just share this map. And really, it puts Alaska on the map of the US. And one of the reasons I like to show this, partly to really think about the land mass of Alaska, we are about a fifth of the size of the entire United States. But also this shows you how we have to get our healthcare delivery to different parts of the state. We have basically a spoke and hub model of healthcare delivery, where you have small village clinics that then have sub-regional, a little bit larger clinics. The sub-regional clinics are staffed by community health aides who operate under other providers. The clinics at the sub-regional level have mid-level providers. Then there's about 8 regional hospitals, and then the only tertiary care is provided here in Anchorage at the Alaska Native Medical Center. So you sort of have this, people have to travel a far distance. So if you think about, the high burden of colorectal cancer is impacted by this vast geography and the resulting difficulty of access to cancer screening. So not many people are keen to get a cancer screening in the first place. But imagine if you had to fly from New York to Miami to get your cancer screening done. How would that might impact your willingness to do it and the system's ability to provide it? And when I say fly, I mean that literally. Most Alaska Native communities are not connected by road and require small aircraft to access. So here's an example of getting off the plane and getting into town. As I said, we have these community health aid clinics, and so they're, generally small, couple exam room buildings where people get most of their acute care and visits to, like, well child visits and that sort of thing. Then the regional hospitals are owned and operated by tribal health organizations. And the tribal health organizations provide all the care to the people living in their communities, in their regions. So for example, I've been working with one tribal health organization. They're responsible for care to 52 villages, people living in those villages, and it's the size of Oregon. So if you think about how you do things, we tend to be very creative. And then lastly, as I said, there's the Alaska Native Medical Center that's here in Anchorage. So colorectal cancer screening, there are several screening tests. We primarily have been focusing on colonoscopy because of the high rates of colorectal cancer and precancer among Alaska Native people. That being said, colonoscopy, this map shows you Alaska. And the things I'll point out, the red lines are the only roads. And then the black dots are all of the communities. So it really gives you a sense of, and the little blue is the rivers, because the communities are often along the major rivers. So you really get a sense of, you have to fly to get to these places. You're not going to drive there. And so the blue stars are where colonoscopies can be done. Now, only about 8 facilities have colonoscopies available, and half are on a continuous basis. Others have a screening clinic that's provided maybe a couple of times a year. So if you think about how you might, if you need a colonoscopy, but you can't get one for a year, you were out at fish camp getting your salmon when they had the clinic. And so then you have to wait for a long time. So it really does make it a challenge to get people to get screening. That being said, we've actually had some really big successes in increasing screening. A screening rate among Alaska Native people for colorectal cancer has doubled over the last 20 or 30 years. And it is now, this slide shows the screening rates, and we've actually now, instead of Alaska Native people being below non-Native people in their screening rate, it's actually now slightly above. The 2020 data was about 71% of Alaska Native people getting screened. So this is a sizable accomplishment. It's something that we really celebrate, the increase in screening. We've been working very hard to get that done. But it is something that, that still means 3 out of 10 people have not gotten their screening, right? So that's something we still struggle and try and get. And then partly it's a challenge. This sort of shows you throughout our state, the screening rate varies by tribal health region, ranging from about 50% to about 72%. So it's one of those things where some places it's a little bit easier to get people to screening and help them out. And then other places are more challenging. That being said, it's not always the places you might think. So we do have some really high screening rates in places that are really hard to get to, and you have to fly, and they have bad weather, and so I have myself stood on an airstrip, wanting to go home, looking up at the plane that's circling above us, and because of the cloud ceiling, they couldn't land, and they circled and circled, and then they left, and we were there for another couple of days. So it definitely, those kind of things are a challenge. And I think that often plays in, though, of why don't people get screened? And so, we often think about from the perspective of, oh, everyone should just get screened, and we will just make them aware, and then they'll go get it done. And that's not how human behavior goes, right? And maybe some of you might, if you can think of some of the personal things, like why wouldn't somebody want to get screened? And I'd say that, there's the sort of the ones that we know of, fear and discomfort, feeling healthy, or not wanting to travel, being busy. So these are all things that are very common when you ask people and talk to them about screening and that they need, that especially if you have to fly somewhere to get a colonoscopy, that's time away from your family and needing to have somebody go with you because of the sedation. But I'd say there's also a number of system factors, and this is something I think is really important, in that screening is not always available in communities. Sometimes you don't have tracking systems for screening, or a provider doesn't know a patient is due. And truthfully, one of the big things is having a provider who recommends screening has been shown to be the strongest predictor of screening in multiple studies in multiple populations. So it's not just Alaska, that's true in many places. So how do you make the system better so that people are supported in getting screened? And I think that makes a big difference if you want to reduce the disparities, is to have the supportive system that then, it just becomes part of regular life, that it's not something unusual. It's just, you turn this age, you get this done. And so we have a colorectal cancer control program. We are funded by the Centers for Disease Control and Prevention for a multi-component program to improve colorectal cancer screening, help patients to navigate through that screening process. Now, the primary focus of this program is on primary care clinics and sustainable increases in screening. We do that really focusing in on clinics and using evidence-based interventions. And so some of them are patient reminders, are one of the focus areas, like sending letters. I will say, here's somebody getting a postcard. And then also, we have been starting to do it. I will say COVID has been a challenge for many things, including cancer screening. But one of the things that we have found helpful is to pivot some of the text messaging that was put in, platforms that were put in place for letting people, getting their vaccination appointments or doing their COVID testing and getting results, and trying to pivot some of those things that have been put in place for COVID to actually be used for cancer screening as well. So that's been a really nice way to try to increase screening rates. We also work on reducing structural barriers. So we're starting to do more with take-home stool tests, which is another way to get people screened. Doing campaigns, sending things in the mail, trying to get them, getting something to your home so that you can get screened at home in privacy instead of having to fly. Again, just trying to figure out any way that we might get stuff to people. I often say that, you look at like fast food companies and their message is everywhere. And so our message should also be everywhere. It should just be at the clinic and at the post office, and somebody, talking about how they just went and got their colonoscopy and it wasn't a big deal, and somebody else is just it's just part of life. So another piece of that is provider reminders. So again, healthcare systems, and I don't think I'm talking out of turn. It can be really challenging with electronic medical records to make sure that the record is updated and it's easy for the provider to see where the information is and know whether, somebody who's come in and they're there for their diabetic foot check, and that it also has a little pop-up reminder that they need colon cancer screening. As we know, people with living with diabetes have an increased risk of colorectal cancer, so even more so, those people should be offered screening. So again, trying to make sure that the tools are in improving the clinical workflow, improving provider reminders, making sure that there is data, that it's clean and it's good and available for people. And so that's been some of the things that we work on extensively. We also work with providers on assessment and feedback. So trying to motivate them. There's been some work around internal scorecards and financial incentives, reviewing their electronic health record data, which teams have the higher screening rates. All of those things can really help increase the screening work that people do. But I would say of all of those things, patient navigation by far seems to be the most effective way to get people screened. If you have people who are Alaska Native themselves that maybe speak Yupik or the local language, that are from the community, it just makes a difference. Having that high touch work where you call somebody up and you let them know that it's time to get screened, and give them some of the options available and help them walk through what they would need to do, and listen to their concerns and figure out ways to help them get in for the screening and be successful. It makes a difference. And it doesn't have to be people who are doctors. It doesn't even necessarily have to be people who are an NP or a nurse, RN. This is a picture of Jocelyn. She was one of our patient navigators. She did end up actually going on to get her nursing degree, but while she was doing navigation, she had not had a lot of education in the health field, but she was caring, and she was wanted to help her people, and she got into it and really got motivated and was able to motivate other people. So it's almost I think the attitude matters more than the medical degrees. And that really is something that we could chart even and saw, where we had a program where we were doing family history outreach. So people who have colorectal cancer, they're asked to provide a list of their family members so that we can do outreach to them, since they need to be screened earlier and more frequently. And so, in the early 2000s, we were maybe getting 30, 40 of the family members screened a year, not that great. And then we hired a navigator, and all of a sudden, my goodness, look at that. It's shocking how much you can get more people screened when you actually are calling them up. And then we added a second, and it just went up from there. So it was really, I do emphasize it's sometimes hard to get patient navigation paid for, but I think if you are thinking about underserved populations and you're thinking about how to get people in for screening, that's one of the key things to make happen. And that being said, we often do a number of community campaigns. So we had one multimedia campaign, which featured previously screened Alaskans sharing their screening stories. So it was both Alaska Native and non-Native folks. There was a couple that got their screening together. There was a fireman who he in his video, he's just like, oh, it's just, peace of mind, real men just go get screened. It's no big deal. So trying to get the message out to a lot of different folks in different ways really helps. We also have giant inflatable colons. We heard that we did a lot of work asking elders and community members how they wanted to get the screening message. And we really heard that they wanted more humor and lightheartedness, that, cancer had used to be a very scary word, and they wanted it to be a little bit less, you're going to die, and more, you can prevent this. And it's kind of funny, and it's a little bit embarrassing and a little bit silly, but you should just get it done, and it's no big deal. So we do have giant inflatable colons. They travel around the state. I'm often shocked at how many people want to, me to take their picture and post it on Facebook of them in the giant colon. We have polyp costumes. I have run wearing a polyp costume in a 5K cancer prevention race. I mean, I feel like, again, it's silly, but it also, people like it, they laugh, then they ask you, what is this? We've had some very successful times at community meetings where we've set up the giant colon. People then can travel through it. It's very good if you have a health educator, walking people through it, talking about it, asking, have they been screened? And then you have a nurse that has a computer with the medical record at the end, and they're like, oh, well, let me look you up and see if you've been screened. It looks like you haven't. We can help schedule you or send you home with the stool test. So you can really, kind of create this wraparound in communities that make it a lot more engaging and, again, just sort of part of the regular life. Now, that being said, also COVID times, we were not doing as many of the in-person gatherings. In fact, many were entirely canceled. So we did have to pivot to doing more of the social media, getting online where people were. So we've creating a lot more of those kind of activities and awareness month activities. We've also started thinking, again, sort of the keeping things funny, keeping things bottoms up, don't duck out on your cancer screening, and no buts about it, big grizzly rear ends. So again, it's just one of those things where you try and think of different ways to get to people, and we've really found that that a little bit more lightheartedness can take that farther. So along with some of our programmatic work, we have also been working to do research on colorectal cancer screening, especially around screening methods. And so a lot of that work has been in investigating the effectiveness of the stool DNA test in the Alaska Native population. So the stool DNA test, or Cologuard, hasn't been previously available in our population. And so we wanted to do some studies looking at whether it would be useful here. And so we did an effectiveness study. We've done some cost effectiveness studies and patient and provider perspectives. So some survey work asking people. And then most recently, we have started in 2020 a randomized control trial of the stool DNA test. And the stool DNA test is a take-home stool test. It's an automated molecular test. It quantifies KRAS mutations and a couple of other genes, as well as has an immunochemical assay for human hemoglobin. So it's nationally available. It is FDA approved, but it hadn't really been used in our system. And so we wanted to see if people would be willing to use it, and also even if it was possible to use. And again, as I said, Alaska Native people have among the highest rates of colorectal cancer in the world, and preventing colorectal cancer is an important health priority of Alaska tribal health leaders and communities. They very much want to not have this be it'd be great not to have one of the highest rates in the world. But as I said, only about 70% have been screened. So our previous work, we did first test the effectiveness of the stool DNA test versus the fecal immunochemical test, which is another take-home stool test. And what was good to know in that study, we actually did a study. Ours was immediately following the FDA approval study that the Exact Sciences, the company that makes Cologuard, and we found our study mirrored the national results. So there wasn't a significant difference in test performance between the Alaska and the national study, which is great. What that meant was that the test performs as well in the Alaska Native population as in the US general population. And so that was something we found very it was definitely, we're like, this is a good thing to know that it's going to work here. And we also then went on to ask patients and providers, like, would you use this? Would you feel comfortable with it? And we found overall that there was a fair amount of interest and acceptability. And then looking at the cost effectiveness, especially given our higher mortality rates and the higher cost of travel in Alaska. And in this, we also found that it would be cost effective. So we sort of had this, it's sort of like, okay, you know, it might be something useful, but would people really use it? And so, you know, we really wanted through this work to find out, you know, especially people, we haven't done a lot of work to learn more about the perspectives of people who have never been screened or who are rarely screened. And so we want to identify strategies to improve screening in these populations. We also want to test the feasibility of creating the Alaska Pre-Processing Lab. And obviously, at the end of the day, I'd like to see screening, another screening method, and screening be able to be increased for people living in rural, remote areas. So the study design, it was a mixed method study. We have qualitative focus groups planned to talk to inadequately screened patients and also do key informant interviews with healthcare providers to really learn more about why people don't get screening, thoughts about the new screening test, ways to increase screening, how to do programs and interventions. So all of these things trying to find out more. And then also to carry out a randomized controlled trial in collaboration with the local tribal health organization providing care in that area of Alaska, which is Southwest Alaska. So in the first aim is to identify patient, provider, and system level factors associated with colorectal cancer screening, preferences, uptake, and follow-up, and really just to find out more, you know, what are the barriers to screening? What might be ways that we could improve these systems of care? And how to really make that happen, thinking about all the different layers of the socio-ecological model. In our aim 2, we're testing the hypothesis that multi-level high and medium intensity community-based interventions can, using the stool DNA test, can increase colorectal cancer screening rates. So that's something that we are right in the midst of as I speak. As I said, it started in April of 2020, which was a challenging time to start a research study. Our theoretical framework, we do use the RE-AIM. I know there's a lot of different theoretical frameworks people use. I love the quote that frameworks are like toothbrushes. Everyone has one and no one wants to use someone else's. So I settled on this because I feel like it's the most appropriate for intervention research and especially implementation research, looking at effectiveness, adoption, implementation, maintenance, all of these things, how they, you can use it really to evaluate collective impact of programs in community settings. So our study is a cluster randomized design. The RCT, we recruited communities and do a baseline assessment to see whether people are due for screening. And in that, we then have the intervention. And so the high intensity intervention is patient navigation. And study staff are do outreach to people through in that intervention group. And then there's a medium intensity, which basically is a mailed flyer and saying you're due for screening, please call us up. And then the control group, the remaining communities in the region receive usual care. So, if they come in for other visits and the provider happens to know that they are due, then they're invited to get screened and then checking for follow-up among all three arms of the trial. Eligible patients are those age 45 to 75, Alaska Native that are living in the region that have at least been seen once in the past 3 years so that we have some contact information for them and that they aren't up to date with screening according to the medical record. So a lot of medical record review before we even do the outreach. Now, as I said, we do send to medium intensity. They get a letter picture of the navigator and some information on the screening options that are available to them. There's a QR code if they want to watch a video. And they are able to have either a colonoscopy or be sent a stool DNA test. Now, the thing that makes this trial a little bit more challenging than others is that I don't know if anyone is familiar with Cologuard, but the kit itself, it needs to be collected and received at the lab in Madison, Wisconsin, the Exact Sciences laboratories. It needs to be received in 72 hours. So from the person doing their stool sample to it getting all the way to Madison. And we had tested this previously from Anchorage when we did our effectiveness study. And we had found that, yes, it is definitely possible to get it all the way to Madison from Anchorage in 72 hours. However, as I showed you earlier with the pictures of little tiny villages, we knew that it wasn't going to be possible to get from the little tiny communities all the way to Madison in 72 hours. So we are working with Exact Sciences laboratories to see if this test can be used by setting up a pre-processing lab in Anchorage. So the kits just have to get to Anchorage in 72 hours. The kits don't have to get all the way to Madison. And this is the first time Exact Sciences has set up a pre-processing lab anywhere outside of their main facility. So it involved a lot of work. They have been very, very kind in providing in-kind support because they are also interested in learning, could this work and could it might be possible to use in under-resourced areas. So the basic process is that the kits are distributed. Patient requests the kit, we send it to them. They have to get it to Anchorage in 72 hours. We pre-process the stool sample and store it in a -80 freezer, ship it on dry ice to Madison. I will say research in the time of COVID, as I said, one of the unique aspects of the study is creating this pre-processing lab. This is sort of shows our little area. When I envisioned this study, I thought we would be doing the research in the lab at the hospital where I work. And then COVID hit and the lab director was like, there is no room for you. You will. And so we had to contact and scramble. We contacted, I think, over 30 labs trying to figure out where we were going to set up. And finally, very kindly, the Alaska State Public Health Lab let us have a little corner and some use of their space to hold our study so that's where we have been. And it's always a challenge, I think, even in regular times, but COVID has definitely impacted all elements of research and programmatic work. So here's just some pictures of us processing samples and storing them in the freezer. So I will say it's been an interesting to do this. We have had to hold off on in-person focus groups that we had planned, although we have done a number of key informant interviews. We are able to do the patient navigation and outreach and the intervention. But even the mail service delivery has been an extraordinary challenge. Again, these little tiny communities, there might be one person that runs the post office, right? So if that person is out with COVID for a week, there's no mail delivery. Or they go on maternity leave. And then also the planes there's fewer planes than there used to be because some of the smaller companies went out of business during COVID. And so getting samples has been an extraordinary challenge. So we continue to figure it out. This is a feasibility study. That's why we do research in the first place. And so we're really trying to learn all that we can about is this a usable test in this population, in this challenging geographic area? And then how can it be used in the future if so? So as I said, it's a 5-year study where we've set up the lab and we're we've done interviews. We are hoping to do focus groups later this year, conducting the RCT. and just trying to continue to work with our partners. We, as I say, I work within the Alaska Tribal Health System. So any reports that we write, any manuscripts that we write, it has to be reviewed by the tribal health organizations. And we try and invite them to participate and be part of that process. And really, at the end of the day, I think of this study as a way to and all of the work that we do, we want it to be that you have research that leads to program or policy change and that leads to improved health among Alaska Native people. And we really want to do that so that Alaska Native people, now and into the future can be healthier and not have to bear the burden of colorectal cancer. So it's one of those things that I think all of this research and programmatic work is really something that we try and think of as a broader system of care and how we can incorporate that within so that it's sustainable, so that it's something it doesn't place an undue burden on patients, it doesn't place an undue burden on providers in the system, that it's set up to support cancer screening just as part of life and do it in new ways. We are also working on a number of other studies in collaboration with Fred Hutch in Seattle, looking at genetic variants to see if there might be something different about Alaska Native colorectal tumors, and really just, again, trying to expand the science, but at the end of the day, trying to make sure that that leads to improved health among Alaska Native people. So with that, I'll end my formal presentation, say thank you very much. Gunashish, Koyana, thank you very much for having me. I do really appreciate the opportunity to share some of what we have done, and I invite you, if you would like, I'm happy to answer questions and have a discussion as well. Thanks.
Thank you, Dr. Redwood, for that outstanding presentation and really highlighting the challenges that we face in trying to address health disparity in the rural communities. Thank you again. I do have a few questions, but perhaps I can have Dr. Charlebois, Edwin, if you want to go first, your hands are up, and then we'll go from there.
Sure. Thank you so much, Doctor. That was really fantastic. Within our Disparities Research Consortium, one of the things that we're really focusing on is community engagement. And so, Dr. Redwood, what have you found in terms of best practices in working with your rural populations and your Alaska Native population in terms of getting community voices heard, closing the loop, like when you find things out, getting that information and getting that information back to the communities, make sure that your priorities are matched. What's not worked very well, and what has worked well? I think we can, because of the multiple challenges that your populations are experiencing, I think anything, your best practices, I think, would be of benefit to all of us in our different settings.
Yeah, I mean, I feel like I try lots of things, and some things don't do great and some things do. So, we very much try and get things out. I would say one of the best things you can do is use existing systems and existing, if there are things that are already happening, whether it's baseball games or bingo night or providers huddle on Tuesday mornings at 7 a.m., trying to use the things that already exist make a big difference. I've tried to hold like a community, engagement night where I brought, food, and I carried like a whole watermelon on the plane with me and no one showed up. Because, who's going to show up on a Tuesday night to listen to some, person talk about healthcare? Like, that's boring. Like, the people are much more likely to show up if there's a potluck and then you happen to ask if you can have 5 minutes at the beginning to just give a quick, discussion about how cancer screening's important, and you have the health aide stand up and you like, come see Sarah if you have any questions afterward. So connecting people within their existing health systems and working within the existing systems that are there already, and maybe strengthening them. I mean, you can do a lot with patient navigation in terms of training and helping them choose right people. But I think that in and of itself is just figuring out what things are the channels and the messaging and the meetings, the things that are already happening, and try and see how you can work your way into that really makes a big difference.
Great, thank you. And it looks like there's a
Yes.
follow-up question from Dr.
Yeah.
Miles.
Yes, thank you. So I see that there is a reference to being new in implementation science with hopes of developing obesity prevention intervention among rural African-American Arkansans. And it says, the question is surrounding, we understand that patient navigators appear to be the best way to increase screening, but funding is a concern. How do you recruit screen patient navigators? What ways are you planning to increase funds to recruit and retain your navigators?
So this is an excellent question, and something that we struggle with. I'll just be honest about that. We did have funding. We had our same Centers for Disease Control colorectal cancer control program funding a number of years ago. We had another 5-year grant for that. And during that time, we had navigators in every region of the state, and they were doing outreach, and they were paid because we had grant funds. That's how we paid them. The grant ended, and all the navigators except one went away. So one hospital managed to convince their leadership that this was an important enough position that they should continue funding this person through, existing dollars, hospital dollars. And unfortunately, all the others, the grant went away, so the positions went away. Now we have funding again, the grant funding again. And so we have been working with the regions, and they have hired navigators. And I think you need to pay these folks. I think, it is work. I don't think it's something that we've tried sometimes to incorporate it as part of other positions. So, they're a case manager, and then they also do a little bit of outreach. And I have not found that to be successful. I think that it needs to be a dedicated position. I mean, it could be, that they're also doing outreach for other cancer screening, but it is one of those things that it really needs to have the time devoted. So in terms of funding, I've seen people, because I ask this question of other folks, and what I hear people say is that sometimes they use foundation funding, that they use, a lot of people are like us and they use grant funding, but I think that there needs to be more of a national push to having these positions be paid and have this be reimbursable, third-party reimbursements. There is, I think, with more of the telehealth focus after COVID, as I assume in other places as well as Alaska, we've definitely expanded that. We were already doing a lot of that just given our geography, but that's really expanded. And I'm wondering if there's a way to make that more fundable just through that. But I agree. That is one of the hardest pieces, is that, it's something we know works. I don't think we necessarily need to research it more to know that it works. You call people up, and it's somebody that knows you and knows your community setting and can help you get it done. But how you fund that, right now we mostly do it through grants, and I don't know that that's a sustainable, something that can last forever. So that's something that we really try to do. I do think I see your earlier question, part of that is about recruiting and screening patient navigators. I one of the things that I think is so amazing is how as long as somebody has a genuine desire to help other people, they need to be a little bit gently pushy. I don't know exactly how to say that well, but somebody who doesn't take the first no for an answer, but is gently is like, oh well, can I help you in any way with that? Like, what are some of the concerns you have about screening, and maybe I can help answer some of that. So it's not necessarily education. I think it's more personality, and that really is a little bit harder to recruit for, but I think is very obvious once you see it.
Thank you for that. Maybe I can ask a couple of questions as well, just having to do with partnering with other really successful programs within, Alaska, one being the hepatitis B, for example, screening and vaccination. I'm wondering, what are your thoughts about that and the lessons learned from those really successful processes? And then secondly, I was curious to know, why Cologuard was selected in that, from a cost perspective, and it sounds from a practical perspective, it seems much more difficult than a FIT testing, for example, that's currently recommended annually. I recognize the 3 versus 1 year difference. On the other hand, there seems to be a lot of other things that need to be supported.
Yeah. So for your first question about partnering with other programs and how they've been successful, certainly the Hep vaccination has been extraordinarily helpful in reducing rates of liver cancer but again, the ways that they have done that, they have dedicated team, and they a lot of times it's been funded by Indian Health Service. There's been direct dollars to send a team out to a community, go around everyone's door, knock on doors, get the health aide helping out, having everyone come and get things done. And so it really, again, dedicated people to do the work seems to be, I feel like I hammer that point home again and again, but it is something that really makes such a difference. And how you figure out how to do that is the payment is a little more the challenge, but going to where people are, having screening available, or whatever the thing is, having it closer to home really makes a difference. And so again, in that vein, why Cologuard? Well, we do have FIT available in most regions of Alaska. I think part of the issue is that it has to be done annually. And we've also seen that the Cologuard test is a little bit better than the FIT in terms of detecting precancerous polyps. And so I think that was part of the reason we wanted to test it out. We also there's a lot of provider resistance to using FIT because it is a concern that the providers, they say, we have this increased risk population. They do seem to have a lot of colorectal cancer. Really, we should be offering them colonoscopy. And so that's our primary screening test is colonoscopy. But as we all know, not everyone wants to get in or can get in for a colonoscopy. So trying to find other methods that could be used for screening has been one of the things that our system has been looking for. And so as part of that, the investigations into using Cologuard, the one nice thing about Cologuard is that it does have a patient navigation system built into the test. So even though the test itself definitely costs a lot more than a FIT, it also includes somebody making those phone calls, checking on the patient, making sure they sent in their sample. And so those kind of that wraparound intervention has been also very attractive to healthcare system, our healthcare system, in terms of being a way to not have as much work on our staff and healthcare staff time, which especially after COVID is very limited, and people are wearing a lot of hats and trying to stretch to cover to provide quality healthcare.
Thank you very much. I have one more question. It may take a little bit of time, but we have 3 minutes to the hour, and this has to do with any notable successes and challenges in engaging with your study community through the process of producing manuscripts or any other phases of the research.
So we work directly with the Tribal Health Organization, and they have been extremely enthusiastic to the point that they did not want to have a control arm. It is very unusual in Alaska to do randomized controlled trials, especially how we are doing it, where we are randomizing by community. So that was something I think only one other study has done. And it's partly because I've been working for a number of years with the different organizations. So people know me and they know that I'm trying to get more people screened. And so this is a way to learn more about how to do that. But I have to, I'd almost say it's the over enthusiasm. They're like, well, we should just offer everyone the screening options. I'm like, well, we need to check, like, does this work? And is it feasible? And will people want it? So it's been a very productive collaboration. I think you do have to build it up over years. There's not necessarily a shortcut unless you are working with somebody who is already working in those communities. Sometimes that can be, a way to jumpstart that interaction. But spending, years working and doing different things, listening, they have tribal listening sessions, so where they talk about what their priorities are. And so we try and go to that and find out what are the things people are interested in. I've gone to many tribal council meetings to present, this is what we're thinking of doing. What would you think of it? Would you be supportive? What might be your concerns? So I think all of that, just sort of ongoing, again, figuring out what the things are that are already happening and trying to show up and be involved really makes a big difference.
Thank you very much once again for that outstanding presentation. And I'd like to thank everyone who's participated in the discussions as well. Thank you.
Take care. Thank you. Feel free to reach out anytime.
Thank you.